So I'm happy to spend our time together talking about anything about that. There are certainly areas where I have a fair amount of technical or structural expertise, but a lot of areas that, I'll tell you, I'll give you my understanding of it, but, it's like trust but verify. If you really wanted a real answer, I can tell you kind of the people that you might want to talk to about that. But if that's okay with everybody, that's kind of how I prefer to do this. Is that all right with everyone? So if we don't mind, maybe we could, I know we got a lot of people here, but maybe if we just want to kind of go quickly, and if you've got a specific topic that you want me to address, I'll make a note of it, and maybe we can kind of go through the room, and then usually I find when I do it this way, things kind of sort themselves into major categories, and then I can kind of do a quick organization, and we can talk about those things in some kind of organizational approach. So if everybody's okay with that, why don't I start at the back of the room, and we can just go down and up, and then we'll take that side. So,
hi.
Yeah.
Kara, I'm Diesel, I'm editor of the magazine.
Nice to meet you.
Kara, by the way, was featured in one of our recent magazines. I don't know how many of you were able to read that, but thank you so much for being part of that.
Oh, sure.
My personal, wow. I'm not by any means thinking of retiring yet, but the day will come. And, how can future or soon-to-be retirees be planning now for, you bring up health care, that's a major concern. What could, I've been working most of my life, so if one day I'm not going to be working, how do you prepare for that next phase in your life?
Oh, great.
Hi, my name is Jim Hilborn. My career was in human resource consulting with Mercer, and retired now and have some interest with a couple of startup firms, but I'd just be interested in, and I realize we could go on for 3 days about the Affordable Care Act, but just if you get a chance, a real overview of your feelings about the impact it's going to have this year, particularly next year.
Okay, so when the new provisions go into place in 13 and 14?
Yeah.
Okay. Give me just a second to make notes so I don't lose that. Okay?
Ray Slabaugh. I also spent my career in healthcare consulting, Mercer, and then my own firm. I echo what Jim said, but I'd really like to talk about, or hear you talk about, the future of the delivery system in the United States. Because I'm well aware of what goes on in other countries. We seem to be the only educated, knowledgeable government that still has a non-socialistic type of healthcare system.
Yes, okay.
Harry Faulkner is my name. I'm a practicing attorney in Sydney, Ohio. This is my wife, and it's a fundraiser at the local hospital. Our question is basically this: how does Obamacare impact employers with less than 50 employees?
Okay. Give me just a second to write it down. Okay.
I'm Trott. I'm at the enemy. I was a pharmaceutical representative. Thank you all very much.
No, we all appreciate all those great medications, huge advances.
As a Medicare recipient, I'm curious as to what the impact of the Affordable Care Act would have on current recipients today.
Okay.
George Stewart, and I spent my career as a periodontist, and my concern again would be similar to all the rest of these about Obamacare and the effect of it as far as individuals, how it might control what we do instead of we being able to make choices like we can right now.
Are you talking as a practitioner, as a provider, or as a patient?
As the patient.
As the patient,
In
okay.
other words, where the things are all dictated to us, we don't have choices as to what the care is like that we receive.
Joyce Stewart, George's wife.
Okay, great.
Carolyn Skinner, and you're addressing the concerns I have with
Okay.
these other folks. I'm going to go on.
She's deferring to you.
I'm Jim McCollum. I'm a clinical psychologist. I still practice in Wesleyan. I'm Jim Mycock. I'm a high school guidance counselor. Pretty much what the rest of you said.
Okay.
My name is Ron Carlson. I've been in health policy for some 40 years in the Department of Health and Human Services, and had my own Center for Health Policy Studies. The question I have has to do with population health and how population health is factored into significant system changes.
How it's factored into what?
Systems changes.
Systems changes. You mean the provider delivery side?
Yeah, I mean, for example, we have a group of people here who are testing new lifespans. And we know that there are going to be new ways of addressing the older person, the senior citizen, and the changes in the way in which healthcare is provided, how that's going to be modified to deal with that population health and behavior.
Very good.
I'm Bob Harris, and I would like to find out what I can about the advantages and disadvantages of working there.
Okay.
Suzanne Harrison, share that same question.
I'm Jack Henderson. I'm a retired physician, private practice, and then missionary medicine. And really concerned about the whole healthcare model today. And I don't know if you want to address it, but we've got to change the educational system in some way. We were all trained to do inpatient care, and there were very few primary care people involved in that anymore. So what about the model? I mean, it's a very expensive education today for physicians, but anyway, it's a real puzzle, and I don't hear talk about that.
I'm Betty Kreider. I understand exactly what Shannon and Bob were saying, just from your perspective of pluses and minuses of Obamacare. We know there's a lot of pluses and there are concerns, so it's kind of interesting to hear perspectives as well. I'm Joyce Christie, and they've all expressed my concerns.
Great.
I'm Lou Christie, and I'll be interested to hear what you have to say about care for the elderly, that is 80 and above.
Okay.
John Lippincott. It probably won't be time, but if you could make a brief comment on a fellow named Grill, who did something in Time Magazine about 6 or 8 weeks ago, I found fascinating.
Yeah, he thinks pretty much everybody's a mess. Probably my biggest comment was to get into all of his details is really intense. Yes, thank you.
I'm Jean Lippincott, who's all of your questions.
Barry Leonard, I was in the temporary staffing business for retirement. I wondered how Obamacare would.
Temporary staffing from a physician standpoint. So
No,
did you know?
from,
You provided.
I was secretary at that time. Not
You provided temporary staffing.
Engineers.
companies. Okay, got it. Okay.
I think if you get answers and suggestions and all the things that we put forward for you, it'll be very interesting. That's why we came.
Okay, all right, sounds good. Let's check back there.
I'll pass it to them for questions.
Okay.
Sandra Shane Duval, I'm a retired psychologist of law with a research emphasis on decision making, and I can't make any decisions about healthcare, so that's why
All right.
I'm Tara Robinson. My husband Ken and I are here in class of 93. I'm a solo practitioner, family physician. I am chief of staff at the hospital in Northwest Ohio. I'm an independent practitioner, just here to listen.
Okay.
Kathy Bryan Smith, class of 64, and I'm just going to piggyback on all the other good topics.
I'm Betsy Peterson. I'm a general pediatrician in a small town in Wisconsin, and I'm a small business owner. I'm in private practice. I work in a community hospital, and a lot of these things are designed towards big companies, big hospitals, employed physicians, and so interested in how it affects me as a small business.
My My name is John Holmes. I'm a retired city manager, or city mangler, depending on who you ask. And I've been putting up with this issue for years in different forms, and it's been very interesting, and I'm interested in how it's all going to develop, and I think that's what you're going to do.
Okay. I'm Suzanne Baird. I'm a preschool teacher, and in our family we've had both private insurance needs and also been connected to large companies. And so I'm curious to see how the Affordable Care Act is going to affect people pursuing private health care.
My name is Dan Beher, class of '83, like Tara. And probably my last 27 years, I am still in the pharmaceutical industry. I work in research and development, and looking at most of you, you've taken drugs that help bring people to you. And you probably still are taking some of the ones I'm working on now. I do over-the-counter work now.
Do you have anything specific you want me to address?
No, my wife's got to come.
Okay.
I'm Alan Cook, class of '63. All my questions.
Okay.
I'm Steve Eastoff. I was a social worker for 29 years with the juvenile court in the state of West Virginia. My concern is with all of the education population seem to be on psychotropic medication and the rising costs of those medications. Who's gonna pay for this, and when is this gonna stop?
I'm Julie Sain, retired school teacher in the class of '63. I am concerned about two things. I look at my report from the health people as to what my doctor got, what he charged, and what they're willing, to pay, and I'm embarrassed. I really am. I don't know how the doctors can stay alive. And so I'd like to know what they're going to do. And what about this sequestering and cutting the budget, and how's that going to impact health? I have a friend in the Social Security Agency. He said, we're in great shape, but Medicare is really not shaping up. So I don't know if there's a question there or not.
Thank you.
My name is Dick Windecker. I did 10 years ago in Information Technologies, and I made the choice of having a senior health plan, and I chose to go with the Medicare Advantage plan. So I'm interested in the future of Medicare Advantage types of plans, as well as, of course, Medicare in general. And also I have a handicapped daughter who gets benefits in my account, so to speak. But she also gets some Medicaid benefits in New Jersey, and that's part of New Jersey. So I'm interested in the future of Medicaid as well.
I'm Phelps Nichols, and I think I'm looking at a little bit of a different angle through a health event that, I should say, a couple years ago, faced with options. And the options given were pretty much unacceptable, which was traditional medicine. And we opted to go a different route. And we were looking at prevention, arresting, reversing. Healthcare costs are killing us. As you know, our major clients are the General Motors, Ford, Chrysler, which are taken under by healthcare. We realize that the focus has been on the wrong end of the spectrum. It's waiting for the event to happen, then how do we cut costs, how do we manage it better. We've taken our company, reinvented ourselves to approach it from the front end, and that is, don't let people get sick. CDC, is chronic diseases are the most costly, most preventable of all health issues. So we're taking that on. How can we prevent, how can we arrest, and how can we reverse chronic diseases, as we did with my wife, from severe type 2 diabetes to complete reversal, no medication within 6 months. So that's our focus, is putting together a team to approach it from that side, because that's where the major impact is. If you prevent bypass surgery, it's $100,000, $150,000. And so we're trying to pull together a team to make a difference right now in doing that. So some of you are interested in that. But I'd like your comment about that, as far as sick care, which is what we call it, and that's where the focus is. Healthcare is keeping people healthy, like preventive, sick care.
Hi, Jennifer, and I was in October 2011 with the diabetes too, and I set a record at the Mayo Clinic, the largest A1C drop I ever seen.
Wow,
Seen in 3 months,
congratulations.
6 of everything. And I had recently my celebration of 1 full year being on all medications.
Wow, congratulations.
Ditto, all the above.
Okay.
To piggyback on that, 2 years ago this time, my bride here on my right had pancreatic cancer. Our son is at Duke University. She had marvelous care there, and here she is today, cancer-free.
Oh, congratulations.
I also am a practicing pediatric dentist. 80% of my patients have some form of dental insurance. Dental insurance is a piggyback to medical insurance. What's going to happen in the future with children? I know they're going to take care of the Medicaid patients, but what's going to happen to the middle class who are working who maybe won't get dental insurance in pediatric dentistry?
Richard Gillespie, class 61, still practicing as a PhD aerospace scientist. And same here by, I'm an expert at WebMD, which I get from my wife's complaining I never go to the doctor. And I see I found out that when you retire and pay for Medicare and you still work, you pay a lot more for your insurance than you do when you're working for an employer. And I want to see, my question is, I have a daughter in Montana, and the father of the Affordable Health Care Act is the senator from Montana, Trott. And I want to know if you agree with him, because he says it's going to be a train wreck, so.
Okay. Yes and no. All right.
I'm Tom O'Connor, class of 63, and I think my concerns have been addressed.
Okay.
Sarah O'Connor.
Okay.
I'm Irene Shutt, class of 63.
Okay.
I'm Phyllis Leonard, class of 63, and I'm interested in the preventive aspect. So many, my husband has a number of severe medical problems, and one of his doctors, and the podiatrist, has turned the corner on this whole preventive idea, and he is refusing to accept patients now who will not take responsibility for their own health. And I'm interested in what you have to say about that.
Holly Vaughn, class of 63. I have major concerns about my own health care projections as I get older. I really have substantial concerns about the millennials and what's going to happen to people in the next generation. Projections.
I just try to get through each day, so.
I'm Larry King, class of 68. I'll turn it over to you. Lots of questions here.
We were just kind of going around and having people, instead of me just sort of barking out a lot of stuff that I think is interesting, making sure that I understood what questions folks had and that we were kind of organizing our discussion and we're going to have more of a conversation. So, talking about things that are of interest to people. So I was just going around the room and so you guys came in last. So you guys.
The Affordable Care Act obviously addressed certain things like broadening the number of people covered, but nobody I listened to thinks it's really going to affect the hospital. We're all, and that's really one of the problems in distribution of healthcare going forward. So what can we do to lower the cost of healthcare to a broader population?
Great.
Craig Bushnard, class of 68.
so, it seems like we've got some, as I suspected, some common themes, but thanks for doing that. That was really helpful for me to make sure that we can talk about things that are of immediate interest to everybody in this room. I think, probably the best way to start is, I always like to start kind of with a basic construct of what the delivery system looks like, because you have several different components to healthcare. You have patients and how patients are caring or not caring for themselves, and I know some of the questions in the room about prevention and whatnot. Unfortunately, there's a lot of factors that affect our health. When we have healthcare issues, we end up entering the healthcare system, and the healthcare system can play a greater role in being more proactive. But when you look at a lot of the issues facing our healthcare system, I find, truth be known, that a lot of those deal with the food subsidies and the food systems that we have. And until we do things that address, and I'm guilty of it myself here, but until we do things that address the mass availability of subsidized, high fructose corn syrup and things like that, which make certain types of food more accessible than the types of food that we would normally be having, and until there's a cultural initiative around health and healthcare as opposed to an activity and things like that, the healthcare system is to a large extent relegated to dealing with problems that are generated from other behaviors that the healthcare system itself can't necessarily impact. But there's no doubt that our healthcare system, largely driven by the financing of healthcare, has migrated to a very focused sick care system. And several of you who are providers, or a couple of you have seen bills and reimbursements, see that primary care particularly is very low in the food chain with reimbursement. And quite frankly, we talk about the law of unintended consequences. I know the gentleman over here asked me, my opinion of the Affordable Care Act, given the Montana senators, very public statements about it. And when the Medicare Reimbursement Act went into place in the 1960s, it created a very bastardized system of reimbursement that is quite frankly the system that we're living with today, and a lot of the issues that we see in healthcare today are driven by unintended consequences from that law that well-intentioned, intended to do a lot of good things, but really created some waves and things that 50 years later, we're looking at and saying, how in the world did it get like this? So you start with the fact that in America, our healthcare delivery system, it kind of evolved from the country doctor, and it's a very cottage industry. Those of you who have practiced there, still to this day, over 50% of doctors practice in groups of 2 or less, and 70% practice in groups of 5 or less. So if you can imagine, you're a physician, and meanwhile, every year, I think the number is there's 10,000 new evidence-based protocols that are coming out that might affect your specialty. So you've got to see patients, or if you're a surgeon, do procedures or whatever. You have an office staff that's dedicated to scheduling and billing, and kind of, what I say is the processing of patients. And you're in a small practice, and there's simply no room there to figure out things like, well, how do I do this better? Because you're really skilled at diagnosing and treating, but you're not necessarily thinking about the big picture of, how do I make sure that this particular patient of my 2,000 patients, who's seen 7 different doctors, and I have 2,000 patients, of which probably 1,500 at any given time are seeing 5 or 6 different providers, many of which I don't know that they're even seeing. They're taking a lot of drugs and things that oftentimes I don't even know, because some of them are over the counter, they've been prescribed by their doctors. There's just no way that a small practitioner can think broadly and have the skill set to be able to figure this out as a solution. But when you consider the fact that 50% of all the practitioners in America are in groups of 2 or less, and 70% in groups of 5 or less, therein lies one of the big challenges that we have And I think, we can, I liken it to trying to solve this problem could be like boiling the ocean. You just can't do it. So you have to have, one little solution, and there are certain types of solutions that can change trajectory of things. But if we think that there's going to be any kind of, massive rethinking of things, we can think it, we can dream it, we can, guide ourselves to it, but to actually accomplish big change isn't probably going to happen in this industry in a short period of time.
Well, why is that? I mean, we've been talking about this for 30 years, and we have systems changes that are an integral part of the Affordable Care Act. Patient-centered medical home, common care organizations are all driving that way and are on the heels of the health maintenance organizations that collapsed.
Right.
Or a good share of them did.
They did.
So what is the barrier?
Yes, that's a great question. So if you think, so let's start with the structure so that you have all of these practitioners and small practices. And I like to think very practically, think about their day and the work. So they are not in the rhythm of treating patients and getting their job done. Providers are not going to figure this out. The ones with some kind of capacity to do it might be hospital systems, but hospitals are under tremendous pressure. So then what happens, you start with that structure before 1960, before the Medicare Act got implemented. When Medicare got implemented, they then found that they're going to start covering people who are of retirement age and providing them insurance. They need some way to reimburse providers. And so they came up with a system, I think you could probably help me out, called the RVRBS system, the relative basis value scale. And it was a way that was trying to equalize, based on work involved, the cost of operating different practices. And in the analysis that was done at that time, the perception was that the primary care practices cost less because they involve, less specialization, less drugs, whatever it is. They cost less to operate than, say, a specialty practice. So the RPRBS system went into place, which still to this day, Medicare reimbursement is based on some facsimile of that, which is reimburses providers based on their relative value of cost. So you end up having primary care practitioners reimbursed significantly less than highly specialized doctors. At the time that the law went into effect, you can just look at the charts. The primary care, the number of people in primary care practices was up here, the number of people in specialist practices were like that. I believe by the early 90s, it had crossed and it continues to decline today. So because the reimbursement is just unattractive and for a lot of doctors when you look at the loans and the cost that it takes to get to through medical school. The reimbursement system rewards more for specialty care than it does for primary care. By the same point, the concept of the reimbursement structure was rather than pay for caring for people, we will pay for actually services rendered. So then you get into the model that we're familiar with today, which is based on productivity. So it's based on the number of procedures you render. It's based on how if you see a patient, can you upcode it and make it, a more complex visit than a less complex visit. So it's all driven, by these cross incentives. And of course, again, there was nobody intended those kinds of consequences. That as a result today, you still have this very atomized delivery system, and you have this structure that rewards for procedures and rewards for high specialists and preventive care, and primary care has really eroded. Meanwhile, you have a growing base of seniors and people are escalating. You have all the non-industry factors that are affecting our health care, and you do see high rates of things like diabetes and things like that. So the healthcare system is more acute. And if you look at the United States ranking on the World Health Organization list of countries, we actually provide, I think we provide 49%, our healthcare costs are like 49% higher than any of the other industrialized countries. and yet our ranking is like 70th or 80th on the list in terms of the outcomes that we get. And we're finding that more care is actually not better care. More care is actually, in many cases, worse care. And what's really happening is you have a whole lot of waste and inefficiency. You have a system that's geared toward doing procedures, a system that's geared toward dealing with people, once they become more acute. And you have a very fragmented
I'm
system.
sorry, what are the 2 or 3 things then that are in the new legislation that are going to deal with those kinds of
So that are attempting to deal with it, I would say. And all that, my view is that all that legislation can do is change some of the incentives. So it can't necessarily legislate that we blow up the way the way the medical delivery system has evolved. They try to solve this now with the Affordable Care Act. The Affordable Care Act deals with several different things. You have questions of, so clearly we've got cost. We've got huge issues with cost, unsustainable there. You've got a fragmented delivery system, and you've got a lot of people who don't have insurance coverage. They get coverage and they may get care, but right now, if they don't have insurance coverage, it's charitable care. Those of you who work in hospital systems, you're well aware of the fact that you have tax-exempt status is because you're expected to provide indigent and charitable care, which you write off. So the Affordable Care Act, the biggest lever that the Affordable Care Act deals with that most people feel immediately is coverage. So it gets more people to have some kind of health insurance coverage by opening up an individual market. And we can come back and talk about that in a minute. It has built into it some things that are anticipated to help drive more innovation around solutions that would cause providers to organize, and more innovations around different reimbursement models. It doesn't necessarily prescribe anything specific, but it allows CMS it has a CMS Innovation Center, which it allows and authorizes certain things to occur that will enable providers to look at organizing slightly differently. And then it has some things that deal a little bit with the cost side, but not a whole lot, because the primary language in the bill is that a piece of it is going to be funded out of all the language by efficiencies in Medicare, but none of those are specified, so we don't really know what those are. And that's part of why you get the reaction from people now into it, looking at saying, where are these coming from, because it's not seen. And it can't continue to come from reducing the provider reimbursement, which every year is slated to go down, and they will not. So to your question, accountable care organizations, patient-centered medical homes are really outside of the ACA legislation. They are fostered by that through reimbursement strategies, but they were already starting to come about. So you have 2 strategies. One is called patient-centered medical homes, which are arming primary care practices and providing additional reimbursement to them if they meet certain standards, which include, I think that the terminology is a meaningful use of electronic medical records, and if they build in kind of some capabilities to work more proactively with patients, particularly those who have chronic conditions like diabetes and things like that, to take on more responsibility for the patients. And there's I think 3 different levels of escalators, if you will, in their reimbursement that will increase their reimbursement if they're achieving certain goals around that. And there's a fair amount of initiative behind that, with the challenge being that providers are having difficulty organizing and finding the business structure to do it. They don't have the business expertise to do it. Insurance companies are starting to kind of mirror some of that reimbursement. So in the non-Medicare space, like in the commercial space, several of the Blues organizations are doing it and are providing data and some case management support to providers who want to be patient-centered medical homes. And the intent of that is that will, if that takes hold at a certain level, that will actually help foster more of a focus from primary care. They'll get more reimbursement, and they'll have a little bit more resources in their practices, and they'll have more ability to focus more proactively on the patients. You see pockets of that around the country. You know, the issue is you know, you've got 700,000 plus medical providers, and you still have big shortages in primary care, and there's a lot of areas of the country that have shortages in primary care, and we're seeing a lot of primary care doctors who are of retirement age choosing, or getting close, they're choosing to leave the practice. So, you know, it's unclear, you know, whether that's going to be, that's a piece of the solution, and all of these, I believe, are pieces of the solution. It's a good piece of the solution. The reimbursement mechanisms in there, I think, are good. The experiments are showing some promise. They're early to tell, so they're showing some promise. And you know, there were some studies in North Carolina that showed some promise around this model. But it's hard to get adoption of it by practitioners, because it's just a very different way, and they don't have capital to be able to do it. There's, in the private sector, there's a lot of businesses out there looking at, you know, can we provide systems, but it's, given that it's a very atomized market, it's very difficult to access it. The other one that was mentioned is accountable care organizations. So the concept
Because in
is...
Maryland, 90% of all the primary care physicians are in a patient care arrangement. Is that not true in other states? In Ohio, for example, that is not the case?
No.
Insurance companies are not motivating physicians to move toward a patient-centered medical home model.
Not really.
They don't see any advantage to it?
It's difficult to administer. So mostly what you see on the insurance side is, I'm sure you're familiar with the old capitation arrangements, right, from the HMO days. And they're, to the extent that they're doing it, they're somewhat viewing it as a means of offloading their risk, because the impact on the insurance companies from the Affordable Care Act is the limitations that are embedded in the medical loss ratio restrictions. And so they're playing with how they can transfer some of that risk to assure themselves of meeting those, so that they don't have subsidies going back to the subscribers. So it's a, you know, it's a very, to the extent they're doing it in very small pockets. Most every insurance company has some kind of pilot underway for it, but they are finding it very challenging.
Yeah, this is Blue Cross Blue Shield in Maryland.
Yeah.
Taking a very proactive role.
Yes, and they're one of the leaders in it. Yep, and we work with them. We work with Chad, actually.
But you don't, that's not characteristic of other states.
No.
You don't find that.
It's not. No, it's not. No. Care First is truly a leader in it, and they were the only insurance carrier to get one of the innovation grants in order to pursue that. But none of the other carriers did. They got a large grant too.
Yeah, they really did it on the basis of their own initiatives. But anyway, I didn't want to.
Yeah, but they are definitely one of
The
the
American
leaders.
Academy of Pediatrics has long used the patient-centered medical home, and so it's an easy model to replicate. So I'm surprised that there hasn't been a greater acceptance and use in the primary care area.
It's a hard model to operationalize for them. So, and again, you just have to think of the practical realities of an idea and a concept getting implemented in a day-to-day operation where things have to change dramatically. And there just isn't a whole lot of resource support immediately behind it. The accountable care organizations, what the Affordable Care Act authorizes is that if systems of hospitals and physicians and primary care and specialists come together, that the Affordable Care Act authorizes a risk-sharing arrangement where they give them certain authority over spending within a population in order to encourage them to figure out how to organize differently and to share kind of that risk, and to create, the way I put it is to take it from this cottage industry into more of a workflow model where everybody's trying to work together, so you're kind of more like an organized entity. My experience is, and I was very involved in the development of the HMO industry. I was very involved in the development of PHOs in the early industries. This is another variation of that with a lot more economic support behind it. And And there are, very well-established models like Geisinger, Mayo, Cleveland, you'll hear talking about Cleveland Clinic, Kaiser, the Kaiser staff model approach, that work very effectively. But what we're finding is that the accountable care organization is very difficult to put together. There's a lot of politics involved in pulling together these disparate groups. The attribution, the way in which patients get assigned to a accountable care organization is very challenging. And there's a lot of barriers to creating that. So what provider organizations are doing, instead of going all the way to being an accountable care organization, is they are engaging in what we call accountable care activities. So they are designing new programs and things that kind of pull together, I'd say, cross-functional care pathways. Diabetes is a good one. It takes a multitude of providers to really deal effectively with a whole system disease like diabetes that affects virtually every body system. And they are having some traction in being able to do that. So there are new provider models developing. My perception is that the good news with what's happened with the Affordable Care Act with respect to the impact on providers is a recognition that the fee-for-service model is not effective and does create cross incentives. Quite frankly, if you look at all the people in America, over 50% of them have their health and care paid for by the government, either through Medicare or Medicaid. The other 50% are in commercial plans. And of that 50% that are in commercial plans, over half of them are in plans that are paid for by only 2% of the employer groups in America. And those are the really large companies, and those are the kinds of companies that are my clients. And the other half of them are in small businesses. And so we'll talk in a minute about the impact on small businesses. So the other half of them are in the 98% of the companies that are smaller businesses, which are generally, say, companies that have less than 1,000 employees. And most specifically, the largest number are those with less than 100 employees. So the good thing with the Affordable Care Act is it recognizes that the structural and the unintended consequences from the reimbursement structures of the past don't necessarily work in the future. It doesn't say what will work, but it creates a venue and a pool of funds. It's over $1 billion that are available through the CMS Innovation Center. They issued a lot of grants here recently to encourage creativity. And it's launched a opportunity for providers to kind of look at strategies around accountable care, patient-centered medical homes, and whatnot to kind of experiment with different models. I think we're going to see, so I think that innovation and that experimentation is great. I think it will help build some opportunities for providers to look at different ways to do things. In terms of the impact of the Affordable Care Act on individuals and small businesses, one of the challenges that's been recognized is it's very difficult in this country to get, because if you don't qualify for Medicare, you don't qualify for Medicaid. There's two ways to qualify for Medicaid. One is income basis, because you meet the poverty level requirements. The other is disability, that you have a permanent disability that prevents you from being able to work and get insurance. But if you're not of the right age, or you don't have a disability, or you don't have a income issue, you basically have to get your insurance through an employer-sponsored plan. And that's where there's challenges. Because if you don't work and you need individual insurance, if any of you have tried to get that, it's been very difficult. So you have pre-existing conditions that you can get excluded on, and they do what's called medical underwriting. So the aspects of the ACA are to, and that's what everybody calls it other than Obamacare, it's ACA, is to create a market for individual insurance. And it basically moved, eliminated some of the barriers to that, so companies can no longer deny you coverage because of a pre-existing condition. And it created a rating structure where you can't have a different medical rate. There's a rate band, so the amount of difference that you can have based on your age and your gender and those kinds of factors, which typically would drive really, really high rates, is limited if you buy through an exchange. And that's what's starting to come online in 2013. So the exchanges are basically an electronic marketplace to purchase individual insurance that for companies that choose to be listed on the exchange. Each state is authorized to participate or create its own exchange. At the last I saw, 11 are prepared to do it, and they launched in 2013. So January 2013, starting this fall, you can start signing up to buy insurance through the exchanges. And if your state does not participate in an exchange, there's a federal exchange that's been created. So insurance companies who choose to participate and offer a product through the exchange, yes.
Okay, I've got that part. I want to raise a question that has bothered me sometimes. Lucky enough to spend my winters in Florida, and there I engage and know quite well people from England, France, Germany, and Canada. Very good friends. And of course, we always bring up the issue of healthcare. And we always say, well, you guys have horrible healthcare, and you all come to the United States for your healthcare. And these are educated people. And they say, what are you talking about? We love our healthcare. And we then look at what we pay for healthcare and what Brits pay for healthcare, and we say, wait a minute, how can there be that kind of disparity? So react to the other systems. And they are the civilized world. So,
I think there's a whole wide range of opinions on the effectiveness of those systems. So there's a lot of data, and there's a lot of studies that suggest that when you get into more intensive healthcare needs, that access to that, the speed of access to that in other countries is a big challenge.
Where's the evidence that validates what you just said?
There are studies out there. Yeah.
I would agree with you on speed. Knee replacements, and we get knee replacements.
And I'm not saying it's a quality issue. No, it's not necessarily a quality issue.
We bring up the same issues, because I come from medical family. We bring up the same issues, and then they say, wait a minute, my mother just, she's 90 years old, and she just had cancer, she got cancer. And she was taken care of, wonderfully in Britain, in Munich.
Right. And I would say that there's a multitude of opinions on that. So I personally, I have my own personal bias. Whether or not it holds weight is a different issue. It's my own personal bias. I actually do not see us in America being willing to go to that kind of a model. I think it's there's enough consternation about what's already been put in place with the Affordable Care Act, and I think it's yet to be seen what the unintended consequences of that are, whether they're positive or negative. I think there's both positive and negative in the bills.
But all of the health indicators that are used by the World Health Organization and comparatively show that we are spending a lot more money per capita and a lot of other measures. The outcomes are better in the other industrial or Western countries than they are in
And I agree with you, and I think a lot of that.
So where's the evidence that argues the other point?
I think the issue really gets into the role of primary care. I think those countries have much more investment, and I think that is a key issue that we must look at as a country, is how can we support and invest in primary care. And I think it's really interesting when you look at what's happening if you have the Medicare and the Medicaid and kind of commercial, but if you look at what large employers are doing, they're actually fostering and securing access to primary care. They're creating primary care clinics in their facilities. So there is a push and a recognition that needs to change, and it needs to change from our educational system, our financing system, our loan system. Everything that we do needs to further support that, but I think that is a key challenge that we face as a country. And I don't have any, brilliant solutions for it. If I did, I'd be president of the United States. I don't think I really want to do that.
Well, the Institute of Medicine laid out a direction.
It did.
And
the Class and Quality Council.
And they've been followed, but you lay some of the burden on educational institutions, from colleges and universities, including Ohio Western University. And if you ask, to what extent does workforce in career building or health professions become an integral part of what this
When you change, I mean, if you just look at the impact that the reimbursement structure that got implemented in the 60s has had, it's pretty clear that if you can change some of the reimbursement structures, you'll drive some different behaviors. It does need backed up in many other areas of, like you said, education, and financing of education. But
if I may,
yes,
I think one of the other keys that you're coming around is that we, as an American system, we don't focus on data and outcomes as the other countries do. When I was in medical school in the 90s, I wasn't taught that you follow a set protocol for someone who's in for pneumonia or diabetes. That's following the cookbook, and that's weak medicine was what I was taught. Now we've learned that those are evidence-based practices that should be followed every single time, and we should have set practices that are the minimum standards for everyone. I also don't think the American population, as my husband has pointed out, is ready to follow data rather than, well, doc, what do you think is best for me?
Right.
Well, here's what the data says, this is what we have evidence for, and that's what I want to guide your care until we see otherwise. As Americans, that's not something that we buy into.
And that's a great advantage of technology that, quite frankly, didn't exist in the medical field, in spite of technology being used to treat, technology being used to operate the business of medicine. I mean, there are still providers with, keeping paper records for patients. And technology has the advantage of getting those evidence-based protocols out to the practicing physicians much quicker, holding more accountability to that. And it's being used in quality measures with respect to quality rankings of providers and reimbursement that's tied to some of those quality indicators. But I think you're absolutely right. I mean, it's just there's a lot of pieces to this puzzle, and if each piece just moves a little bit, it's going to be a lot of improvement in our system. But, I can't answer the question about whether or not European systems or the socialist systems are better. I have my bias. I think there's inherent problems in those. I think there's a lot of ways to improve our systems, and I think we're making progress in that. Personally, I feel that legislating something is not necessarily as impactful. Quite frankly, I think one of the biggest barriers to innovation in healthcare delivery is the dominance of 7 major insurance carriers that dominate the industry, and then Medicare being fairly rigid historically and unable to moderate what it's doing, and therefore as long as those things don't change, providers don't innovate, and they just calibrate to the reimbursement strategies that exist, and you end up not being able to foster creativity because who's going to pay for it? And I think that if we looked a little differently from an antitrust standpoint, and we open the market up, I think it's great that we're going to have exchanges. We have many, many new products available, co-ops. There's a whole lot of new avenues for new kinds of insurance to come out that I think will foster more innovation. And my view is that unleashing creative talent that we have in this country is going to benefit us better than adopting models that are working in different, have certain attributes that work in a certain political environment in different countries. Yes.
Another question.
Lunch starts right now.
Oh,
so.
okay. Why don't I keep you for lunch?
Lunch is right now in the ministry rooms. I think maybe Kara has a few minutes, maybe just take
Yeah,
a couple
absolutely.
one-on-ones,
Somebody
but
needs to be around to answer questions.
I want to make sure the group can get over to the ministry room for lunch.